Yes.
Okay. All right, I'm going to put it in slideshow and we will get started with this last training program. It's been a pleasure working with all of you, and I hope that you have gotten some things from this, and I also hope that you have put some things in the background so that you can look at them when you are at a point in your practice that you can incorporate some of the ideas. Here we go. Okay, so we are starting on module 7, which is the medical neighborhood, what, why, and how. We've all gone over this disclaimer multiple times. So what you're going to find today is, the concept of a medical neighborhood is not always well understood as we would like it. So within the transformation program, this actual term refers to the many services and professionals that can contribute to the health and well-being of the patients and families that you serve. I'm sorry. It includes more than just the principal focus of care and the care team that takes responsibility for each patient. So the concept of this medical neighborhood acknowledges that at times the medical home cannot serve all the patient's needs and desire, and a broader support system is sometimes necessary. So the medical neighborhood would ideally include caregivers and services interacting with each patient. Unfortunately, an expansion in the number and types of caregivers also often increases the likelihood of breakdowns in communication and coordination, which sometimes results in a negative impact on the patient in the form of confusion or duplication of unnecessary services, even medical harm. So a transformed practice working within a medical neighborhood needs to set up those systems in their practice to ensure that communication is open, communication goes back and forth between doctors, and that there's coordination of care. So if you're sending someone to the medical neighborhood, but they're in their own little silo, and they tell the patient one thing, and then you tell the patient something else, that's going to be a problem. That's why when you open up the medical neighborhood, you need to make sure that you are coordinating with all those different people so that the care is coordinated, so that if the patient is asking you something about their diabetes and there are multiple ways to address that, you would contact the primary care and say, I have this patient and they're asking some questions, so I'd like to have a discussion with you to find out that, to make sure that we're both on the same page with the patient's care so that we're giving the same information out. So it can be tricky, but if you have those processes in place with coordination of care, you shouldn't have a problem. And that care coordination is a new term that's been used more and more often. Sometimes it has unclear definitions. In this module, you'll see the transformation program defines care coordination as all the work that the practice does to ensure that the patient and their families receive the care they need from other providers in the medical neighborhood, both within and outside healthcare, and that the practice has those systems in place to reliably close that loop. We talked about a while back, we talked about closing the loop with referrals, making sure that you are getting the appropriate information from the referral, and that the referring doctor is getting the appropriate information back, so that that loop is closed, so that everybody knows what everybody's doing. The old saying with the right hand doesn't know what the left hand's doing. We want to eliminate that process and close the loop. There are several change concepts that relate to the medical neighborhood and care coordination, and those resources provide guidance on what primary and specialty providers are able to do to make the medical neighborhood a place that serves all of each patient's needs. So go back to the overview of everything that we have been working on over the last year. So the change package, which is built on this driver diagram model, describes all the changes needed that'll transform clinical practice and meet those goals. So today we're looking at practice as a community partner, coordinated care of delivery, those kind of things. And so this is a compilation of all the interventions developed, and they've all been tested. So today we will be talking a little bit about using community resources, coordinating care, and ensuring those quality referrals, as well as considering the whole person, the health of the whole person, and making sure that everybody knows what's going on with that patient. So in the change package, one of them, coordination of care. So provide effective care coordination across the medical neighborhood. Then we are ensuring quality referrals. So we're making sure that we engage those medical neighborhood providers to ensure the highest level of service and quality. And also we're going to use those community resources, inventory available for community resources. Start creating a little guidebook of all the community services, resources that are available for patients, and what patients would see what community resource. And also to consider the whole person when you're planning that care. So let's talk about practicing in a medical neighborhood. So here we go. We have a medical neighborhood. We have home health, hospital, primary, specialty, pharmacies, mental health, diagnostics. But we also have community resources, community centers, senior centers, public health, schools, employers, faith-based organizations. All of this works together to create this medical neighborhood. So the first thing you have to do is define the medical neighborhood that your practice works with as the starting point, for implementing these kind of change concepts. So if you are a primary care practice or a practice that cares for people with chronic condition, your practice likely serves as the hub of the medical neighborhood. So if you are a specialist, you may partner with one or more primary care medical homes or those little hubs for patients and serve as the medical home hub for selected patients. Regardless of what kind of practice you have, and we have both specialties on here today, you want to answer the question, who are the other providers or caregivers to whom you refer and who refer patients to you? And then, which are the hospitals, the nursing homes, the therapy centers, the surgical and other facilities that all of your patients are using? And you want to know resources available that you can address behavioral health or social health needs, and what community resources are available to serve other needs of your patients, like housing, justice, education, other sectors. Getting involved and having that resource of a social worker, maybe at the hospital that you are affiliated with, would be a really good way to address those different needs. Getting patients signed up for medical assistance or housing and employment, they can help with that. And so by answering these questions that I've asked, you need to take an inventory of that and define your particular patient's medical neighborhood. But there's more to it. So we talk about practice as a community partner. So let's talk about those community resources. So look at all and inventory those community resources and refer patients as appropriate to access services that you don't offer in your practice. Engage members of the medical neighborhood to ensure a high level of service and quality of care. So you're going to vet all potential referrals and agencies. Then you're going to leverage personal relationships so that you can cultivate good referral opportunities. And then you're going to make that list of all those community resources that you can give to your patients. You're going to work with those agencies to make sure that they are available to the patients and maintain some really good, solid referral links to community-based chronic disease self-management programs, or maybe some exercise programs, or other wellness resources within the potential for your bi-directional flow of information. Bi-directional, give some, take some, send some, give, receive some, make sure that that's all working together. And create that little guide for community resources. And as a provider, employ the philosophy, you should only refer to a provider that you would send your loved one to, that you know is going to be appropriate for that patient. And then create and maintain those referral lists for medical residents in academic settings, if you're in an academic setting. Engage in local health coalitions to identify resources in areas where those resources might be scarce. You may practice in a section where they don't have the kind of resources that they need, and how you can coordinate with some resources where those are scarce. For instance, when I worked in ophthalmology, we provided transportation to patients who needed cataract surgery or glaucoma management. We had a bus that came and picked them up. It was an all-day adventure for them, but we picked them up, we took them, and then we took them back home. So that's how we identified resources in areas where those resources were scarce, but we were able to take care of those patients. And then find out about how the patients actually define quality of care. Talk to them, use those surveys, ask those couple of questions in surveys, and make sure you build it into your practice model, what they actually tell you. And somehow or another, make a referral tracking system that assures loop closure. So make sure the patients are keeping appointments, making sure the patients have got information, and also making sure that there was a report received. Excuse me, I'm sorry. Get out if you're going to bark. So let's talk about effective care coordination, making sure that care is really coordinated and it's effective. So that effective care coordination, make sure that the caregiver has all the information they need about the care that was rendered, the services provided, and the information that was collected during previous encounters with other providers or in other settings. This would include information on transitions to or from maybe hospitals or nursing homes, or even just your providers, the referrals back and forth to your provider. You need to make sure that you're not duplicating, and we've talked about this in assessments, but medications, lab results, diagnostic tests, or observation, we don't want to have duplication just because the information was not received. So if you're providing effective coordination, then it's a systems approach. It's something that you have to do. You have to review the patient's chart. If the patient had lab results or diagnostic tests by their primary care, and you need those tests to do that, reviewing your patients that are coming in a couple days before and giving the time for someone to call or to send a fax or an email requesting those lab results, or being able to go, where did you go? Oh, I went to LabCorp. Okay, so you can go on LabCorp's website and pull those into your EHR. So just making sure that you've gotten everything. I used this example before. I went to the cardiologist and I went to the primary care. They both gave me requests for lab work. I went to the lab, took both requests and said, can you make this one request and send whatever the primary care wanted and send whatever the cardiologist wanted to them, so that we didn't have to duplicate that information because they didn't have it available. And make sure that communication between the facilities and the physician's offices about admissions and discharge. CRISP is a wonderful tool to give you that information and to help you coordinate care with those patients coming out of the hospital to make sure that you know exactly what went on there, because a lot of times in the hospital, they change the patient's medication, and you're going to need to know that in order to correctly treat that patient. So also assigning that responsibility for care coordination or patient outreach or closing the loop. You know, we talked about this in module 5, managing referrals, and creating these well-defined workflows that have a really good degree of reliability so the patient will remain engaged and neither they or their information can fall through the cracks. You want to make sure that everybody knows what's going on with their patients. And then your coordinated care actual delivery. So effective care coordination across the medical neighborhood will develop some compacts between primary care and specialists and assign responsibility to specific staff members for care coordination and referral management. Maybe that's your MA. Maybe you're asking your MA at the end of the day to review all the patients that are coming in 2 days. I will give you an example. I had a doctor's appointment with my primary care. Population health called and said, I noticed that you haven't had a Medicare wellness visit in the last year, and you need to have that done. So I'll set up an appointment for you to come in with one of the nurse practitioners and have this performed. And I said, okay, and I made the appointment a month later. Well, when I went to see the primary care, he actually did the wellness visit. And they called me 2 days before my appointment for the wellness visit and said, we see that your doctor already did the wellness visit, so you don't need this appointment and we'll cancel it. That's effectively communicating with your patient and making sure that there's no duplication. For a wellness visit is only billable, I think it's every 6 months. And so if you have that in between, it's not going to be covered by your insurance and you're going to be responsible for it. So you have to work that out with your patients and with your staff to make sure that they're following through with that. And also that two-way exchange within the medical neighborhood and making sure you're closing those loops. Maybe participate in health information exchange like Chris. Use those referral notes, use some structure, get some structure in those referral notes to make sure the information is standardized. And that way everybody can see exactly what's happening. Maybe establish some of those coordination agreements with those consultants that you use on a regular basis so that the documentation of flow can be really easy between the 2 patients. And make sure you track those patients that were referred through the entire process. Integrate that information from referrals into your plan of care as well. And make sure the primary care team requests those urgent appointments for specialist consults. Sometimes you have to, if you ask the patient to do it and they say, well, the next available appointment is way out there, then you can have the primary care team call and request the urgent appointment so that they can describe exactly why they need to come in so soon. And have a shared care plan if you co-manage patients. And establish that mutual understanding of information that could be shared when it's transferred or shared among providers. In specialty practices, for each referral, notify the referring care team of the date of scheduled appointments, as well as if the patient cancels or they no-show, so that the team is all aware what's happening with this patient. Evidence-based care is so very helpful. So let's think about the whole person. Let's consider the whole person when planning care. So you wanted to develop that formal referral relationship with mental health or substance abuse services in the community. You also want to make sure primary care and other clinical staff has been trained in the principles of behavioral health in order to handle routine behavioral health care needs. And then Include use of non-clinical staff to do those behavioral health screenings, like the depression screening, those kind of things. Use your non-clinical staff. Have them do those assessments. Maybe put it in your electronic system when it reminds an appointment, and the patient can fill that out before they even come in. And make sure you're having regular communication and coordinated workflows between the primary care and those behavioral health providers. Conduct those regular case reviews for, sorry guys. For those unstable patients who are not responding to the treatment. And use the registry function of the electronic health record or some kind of shared registry to support active care management and outreach to those patients in treatment. Make sure those advanced directives are included in discussions with the patient and the family. Make sure that the patient has completed an advanced directive. And I believe that Medicare will reimburse you for discussing that with your patients. Then integrate behavioral health and medical care plans and that facilitate integration through co-location of services when it's feasible. Think about those dentists, oral health services into primary care and specialty settings. So oral health, even though I am not a happy proponent that oral health is not covered by health insurance, and it's covered by dental insurance, but not everything. But oral health, as you all know, is really an integral part of the patient's health. And patients who have, I think it's mitral valve issues, they have to take an antibiotic before they have any issues. And making sure that you're asking that question or making sure you know that about the patient, and you're telling them about the dentist, or maybe you're saying, do you go to the dentist on a regular basis? And if they say yes, say, remember, if you're having any kind of oral surgery, you have to tell them that you have this mitral valve problem. So it's just communicating and thinking about all of that when it happens. I know it's a lot, but this is where we are going with healthcare. So that is the end of this session. Again, here are a list of tools. The American College of Physicians has a high value care coordination toolkit. This link you can click on. There is another one called Hope Note Toolkit, and this also has lots of information in it. And I highly encourage that you peruse this at your own time and own space when you need to. And I'm going to turn it over now and ask if there is anybody who has any questions about this. Who has a question or a statement or something about this program? Anybody? Did I put you off to sleep? I guess I kept you awake from sneezing. Okay.
Yeah. Hi, it's Dr. Gandhi, Darlene. So I'm just gonna say real quick. Yeah. So, I think and then you made the point, like, I think as specialists and subspecialists, we all have a slightly different sort of medical neighborhood, depending upon like where we fit into that chart that you showed in the care coordination of the patient. And of course, primary care specialties tend to be more in the middle, doing a lot of the care coordination. But I think it behooves all of us as specialists to participate in that role as well. I think we're learning this more and more with, particularly with thyroid eye disease as a disease process and condition that we are treating more and more now with medical therapy and doing less surgery for those patients because there are more treatments available now, but it requires more careful coordination with our colleagues in endocrinology. And so I think that's like just one example, but it's an important example that illustrates that, I think patients stand the best chance for the best outcome if providers coordinate, from the get-go.
Yes, very helpful. And I agree with that completely. It's really important for all the providers to know about their whole patient, not just the portion that they happen to be treating. Because that's where the best outcomes are going to come about. And that's where it's coming. And, you know, my daughter is a OBGYN and she does maternal fetal medicine, which is all high risk pregnancies. And we had a discussion the other day and she said, we are trying so hard to get all of the information on our patients because we have the sickest of the sick. And she said, and without that information from the primary care, it's almost like we have to start all over again because we have to try to determine that. And so that good feedback of information really is what helps the patients the best. So, anyone else have anything, does a primary care have anything to say about what Dr. Gandhi was talking about as well with care coordination? I think Manny, you guys do a great job. You have a good referral network and you do a really good job of trying to make sure that you're giving information and receiving information on a regular basis. We had a conversation about that the other day.
Yeah, so we Athena does a really good job in sending the referral and getting back and forth the information through faxes and patient communication. And if we need to send to the referrals, they send us back whatever is required for the pre-op or anything. Athena does a very good job in doing that, all that things.
Yes, and you said you're able to actually get the information and download it into Athena.
Yes, so like labs and community radiology services, we can check with them if they had the previous labs which the other doctor ordered. We can pull out the results from them, and they also send us the fax of all the information and all the regular chart notes with the specialist we refer to has written under their charts. So yeah.
Anyone else? Sophia, talk a little bit about, so you're doing, you're opening a substance abuse practice, correct? I think she's on.
Yes. And I
Yeah.
offer Chris to help manage to see what patients are on and who's prescribing what and things like that.
So that's really important to your particular practice because you have a lot of medications and multiple interactions and what the patients are doing or not. So this really good care coordination helps you to do a better job with your patients that are having issues with substance abuse, correct?
Correct.
Okay, so Anene, are you able to post the link for the attestation? You did get the attestation, everyone, in your, oh, here it comes. Oh, Allie put it in. So here is your attestation for training module number 7. And you've all done this so many times. So I'll let you fill that out. Click on the radio button, training session number 7, and submit that. Once you have submitted that and gotten the thank you screen, please drop off the call so I know that you have done it. And I thank you for your participation today. And I thank you for listening to all these training sessions. And I sincerely hope that all of this information that you've received over the last 7 sessions helps to make you provide better care for your patients and help you to coordinate the care with your patients.
Thanks, Darlene.
You're welcome.
Yeah, thank you so much. It was really helpful. Thank you.
Good, thank you. All right, so it's in the chat screen, or it's in the email that Anene sent out yesterday afternoon.